chair our session as usual. And you can see that I'm already dressed,
we
able, waiting patiently. And yes, uh, let me congratulate as ever. Our meeting has always been very wonderful and has been very fantastic. Today again, what we are going at is promising, is promising, is promising. And that be as it may, the health sustainability triangle focusing on her hospital-acquired infections, infections, and so forth is going to be a very rewarding time. Let me say that Dr. Sahid is doing a very fantastic job. So also everybody that has taken it upon themselves to be in attendance. I will be otherwise busy in the next 10, 15 minutes before I finish my meeting. Professor Yusuf,
yes.
thank you so very much for
Yes, Professor Yusuf also
join
has
us.
joined.
Chef Hina.
Yes,
Chef Hina, thank you. I could see you. Mr. Hamsat Ademola,
My
you
pleasure,
are
sir.
wonderful. Richard Welishi, the Naib
My pleasure. It's
Ashan,
an honor to me.
thank you so very much. We are very glad having. We can assure you that it's promising and it's going to be a very rewarding time as we are here together. Thank you so very much. I wish us a very wonderful deliberation. Dr. Saeed Adebisi, over to you.
Thank you so much, and I want to sincerely welcome our guest speaker for today, and that is Mr. Hamsat Ademola. Yes, before we go, Professor Florence Yusuf, yes, let us hear your voice. Let us hear your voice.
Thank you very much, Dr. Adebisi. Thank you very much. I want to say a very great good morning to everybody, and I want to thank Dr. Adebisi too for his efforts, or relenting effort to get things done. I want to appreciate you. I want to welcome everybody to this section. And honestly, last week one was so fantastic. We learned a lot. And the way we are going to learn more today. Because when you see that topic, it affects everybody, including myself and everybody involved, if we want to be truthful to ourselves. So it's a good one, Dr. Adebisi, and I appreciate you. I appreciate the last guest speaker, and I know today we are going to learn more too. So thank you.
That is Mr. Hamsat Ademola. It's been the first time on this very program. We would like to learn from your story a bit, briefly. Who is Mr. Hamsat Ademola? Thank you.
Thank you very much. Good morning, everyone. I want to sincerely appreciate the confer of this program, and because at this critical stage, there are a lot of issues that needs attention, and this is one of them. So I am Hamsat Ademola Ibrahim. I'm a medical laboratory scientist with the University of Ilorin Teaching Hospital here in Nigeria, and I have my bias is in medical microbiology and parasitology, especially as it comes to effect of biofilm formation on antimicrobial resistance. So I have my first degree from Ladoke Akintola University of Technology in the year 2012, and I have my master's degree from University of Ilorin, which happens to be the mother school of the hospital where I work as a medical laboratory scientist. So I have a lot of a few certifications on antimicrobial resistance, especially with the WHO, and I have some other certifications with the University of Washington, especially on leadership, management, and some other few epidemiological courses. So I'm very happy to be here today, and I hope that the program is going to be beneficial to all, including myself. Thank you very much.
wonderful, wonderful. Thank you so much. And yes, before we go into the presentation proper, we would like to ingest some sense of familiarity into this very discussion, meeting you for the first time. What actually prompted you to this profession? Is it that from the beginning, that was what you intended to actually do, or circumstances of study and circumstances of a university system push you to that system?
So thank you for this question. To be sincere, going by my background, because I used to be a very good mathematician back then in my secondary school days. In fact, I had distinctions in my mathematics, further mathematics, physics, and chemistry. In most cases, at least for few attempts of my O level I did. Biology has been an issue, but then one of those things that actually tailored my ambition is the fact that I've always wanted to save lives. And I think being in the medical profession will actually do justice to that in a way. However, another thing that came up later was which aspect of medical profession. As you know, just like any other field, there are a lot of sub-fields under each of them. That's the same scenario we have in the health sector. So initially, my plan was to do MBBS, just like any average Nigerian. And but along the line, I fell in love with medical laboratory science because of the pivotal role it plays in health sector, as it is the oracle of the medicine as a whole. So it interests me the more if I can actually with analysis solve people's problem and create a lot of information that can be useful to manage patients. So I feel if I am the foundational information needed for diagnosis, prognosis, and management of patients, then I think I'm fulfilled, as my primary reason for coming into medical field is to save life. So that was what prompted me. So when the journey started, another issue was to take to specialize, because there are a lot of fields under medical laboratory science itself. So we have some major ones and we have some minor ones. So major ones that we are all familiar with, we have chemical pathology, medical microbiology and parasitology, we have histopathology, we have histopathology, we have hematology, we have immunology, we have we have molecular biology, we have forensic science. A lot of them are there, but because there are limitations to those that are available to us in this part of the country, so the major choices we have, the major ones we have here are just four. The four I initially mentioned, that is chemical pathology, medical microbiology, histopathology, and hematology. So when it was time to make selection out of the four at my finals, so it became a very serious ordeal. But then I was like, instead of just studying one life, why not two? So I found out that microbiology, aside, it involves two different lives. As you are studying the life of the patient, trying to assist the patient, you are also studying another life, that is the life of the microorganism. So this interests me the more. And then I fell for it, then the journey began. So when I entered the field, I found out that this second life I was talking about, they are fascinating, they are interesting to deal with, especially as they have a lot of traits, interesting traits. And that was what prompted me. I was trying to see how do I actually bridge all the most of the traits they have. There are two particular traits that are very, very important in microorganisms to us as medical professionals. One is the virulence factors, that is those factors that what's called make them cause infections, while the other one is the antimicrobial resistance profile. Because if an organism is able to cause infection and it was properly managed and you use an antibiotic and it works for the patient, then the threat of the infection may be minimal. So, but where in cases where you have, yes, you've established an infection, then the antibiotics is not working for the patient, then the patient becomes hopeless. So that what's called bringing the two of them together, that is virulence and resistance, and that is why I work on biofilm formation, which is one of the cardinal virulence traits of microorganisms, and the antimicrobial resistance. So and that has been the journey so far, and that was what I did till my master's level. Next slide. Okay. So this discussion will be based on the outline as shown. So just like we all know, hospital-acquired infection is also called nosocomial infection. However, the standard name now is a healthcare-associated infection. So the reason why we have this change of name is that we found out that some healthcare-associated infections may not be gotten from the hospital. So some of them are carried right from the community into the hospital. So that is why, to ensure that it is all encompassing, it's just that it manifests while the patient is in the hospital. And that is why the name changed to healthcare associated infection, just to make sure it encompasses all aspects of infection that starts or that manifests while the patient is in the hospital. So they are, just like I initially said, they are infections acquired during the process of receiving health care, so that were not present at the time of admission. So we want to make sure that we exclude diseases or infections that are primarily from the community. So because they have unique differences between the two, that is the community acquired infections and healthcare associated infection. So they are very they are a major threat to the healthcare system globally, because they cause a lot of adverse effects on healthcare, and they affect patient safety a lot. In most cases, patients end up dying from hospital or healthcare associated infection, not the primary infection or primary disease condition that brought them to the hospital. So this makes it a very, very great challenge to the global, what's called the public health, because we cannot imagine a patient coming to hospital having a non-infectious disease, for instance, diabetes. So diabetes mellitus. So maybe when he has diabetes mellitus, the patient has an ulcer on the foot. So at the time of hospitalization, the ulcer got colonized with an hospital with an infectious agent in the hospital. This may be the eventual cause of death of the patient. So that is to tell us that this is a very great challenge to us. So and that is why it is very important, and it's called for concern from all quarters. So there are basic parameters that we use to actually determine that an infection is an healthcare associated one or healthcare related one. One of them is the time of onset. So it is stated that an infection that does not take place before 48 hours is not considered as an healthcare associated infection. That one is actually, it has been incubating in the patient. It has not just manifested. So that means at least 48 hours. The patient must have spent 48 hours in the hospital setting before we diagnose a patient to be having healthcare associated infection. Then other factors that affect it is the patient's health status and others like that. So it causes a lot of financial burden with extended stay in the hospital, because at the end of the day, a patient that has come for treatment of diabetes, for instance, just like I rightly said, But I've just been managed with some what's called glycemic control drugs and possibly been discharged. But during the course of his stay in the hospital, he got infected. He got infected with one of the etiological agent of healthcare associated infection. Then another journey starts. So it causes a considerable financial burden, or it have extended stay and increase in hospital cost, and they are caused by a varieties of you can see just like the slide being projected here, the sources of infections in the hospital. You can see them. Some of them are not primarily from the hospital. It may be you that you are even coming to visit a patient that is bringing it. The reason is that there are some organisms, primarily when they are at some site in the body, they may not cause harm. But by the time they get to some other site, they cause harm. Or by the time they get to some patient, they cause harm because of the health status of such patients. So when you have the source of infection in the hospital may be other patients. A patient come with an infection, then another patient that does not have an infection, that is battling with another disease condition, got infected from a co-patient. So that's one of the sources of hospital-acquired infection. Another one is the visitors. So when they tell us that still they are visiting hours, when you are coming to the hospital, don't do this, don't do that, or you don't have to come, there is no point coming. They are not doing that because they are striving us of our humanitarian, humanitarian traits. No, they are doing that for the safety of the patient and other patients in the hospital. Because as we are coming, there are a lot of germs we are carrying on our hands, on our bodies and the like. So by the time we come around, we drop them, then the patient who is already immunocompromised because of the state picks them up. Then from there, it becomes a problem for the patient. Then hospital personnel, this is another source of hospital-acquired infection. Because doctors' hands are reservoir for infectious agents. So we've seen there are a lot of studies that have been done where interdigital space of physicians was swabbed, cultured, and by the time the culture reports came out, we found out that there are a lot of microorganisms that are multi-drug resistant. That is, they are resistant to a lot of antibiotics, and these are people that manipulate patients. So it is easy for such individual to transfer the organism to the patient. So hospital personnel are also source of infections in the hospital. Another source is surgical procedure. There are a lot of surgical procedures that cause healthcare associated infection, and the reason is not far-fetched. From contaminated medical equipment to there are some cases where as one of the reason why the name healthcare associated infection is adopted is because a patient may be carrying an organism at a site. So when a surgery is being performed on the patient, especially when it is an invasive procedure, just like surgery. So during the course of the surgery, the surgical equipment were sterile, all of those things are sterile, but as they are piercing the tissue of the patient, they are transferring organisms from sites that are where they are normal flora to a site where they become pathogenic. By the time they get to that site, they cause infection. Primarily, the organisms are from the patient himself, but at that point, the patients do not come down with the infection because the organism at that site is not causing any infection at that site. It's the normal flora at that site. But at the time of trying to operate on the patient or carry out any surgical procedure on the patient, the organism is pushed to a site where it causes disease. So that is one of the reasons why surgical procedure is one of the source of hospital-acquired infection. And another one is ear. There are some organisms, we call them aerobic spore bearer. They are present everywhere. So that is why when you see in a standard hospital, they keep on sterilizing both the physical and the unseen, because the hair also can be what we can call a host or something like a reservoir for microorganisms that are multi-drug resistant. Another one is water and food, just like we know. So water can get contaminated, food can get contaminated with these superbugs, and they get to the patient or to the hospital environment. Then another one is the patient normal flora, just like I said earlier. So patient normal flora, you know, when you have normal flora at a site, it may get to another site where it becomes pathogenic. Just like we have in our GIT, there is a lot of enterobacteriales in the GIT. Enterobacteriales are organisms that normally reside in the GIT. So by the time they get to another site of the body, they become a threat. So, and some of the enterobacteriales in the GIT, they are multi-drug resistant enterobacteriales. In fact, I remember one of my supervisors, or let me say one of my lecturers back in school. And in fact, I have a lot of some of my colleagues, and in fact, unfortunately, he was a supervisor to he was a supervisor to some of my colleagues that are on this forum. He was working on a CRE, and I think one of them also worked on it. So he was working on CRE from intestine of a normal healthy individual. CRE means carbapenem resistant enterobacteriales. That means they are there. They are not causing any harm, but they are already resistant to antibiotics. By the time they have any opportunity of crossing to a site where they can cause infection, they will be difficult. Such infection will be very difficult to treat. So that is why not only they are normal flora before, but by the time they get to sites where they can cause infection, it becomes a very big problem and it becomes a major threat. So then we have fomite. Sorry, I'm still on this level. So we have fomite. And fomites are just like foams and beddings that were used in the hospital. They are reservoir of infectious agents that may harbor antimicrobial resistance. Then we have devices, just like I said. Example is catheter. When you have patients that have indwelling devices, they are major source of infectious disease in the hospital, because whenever a device is inserted into a patient, it creates a room for that organism to form what we call biofilm, an organism community, where they can share ideas, just like we are rubbing mind now. Organisms also rub mind. So, but when they rub mind, they are exchanging dangerous weapons. They are exchanging antimicrobial resistance traits and the likes. So now, then you have the healthcare associated infection. Now, a case study in the European hospital. If we look at this projected slide, it's made up of 100 people that visited European hospital, out of which 6 of them were diagnosed with healthcare-associated infection. So out of the 6 that were diagnosed with healthcare-associated infection, you have some of them. We have 23% of them that are already present at admission. But don't forget that we are saying that healthcare-associated infections are supposed to be while the patient is on admission. But we have 23% of these that are already present at admission. What does that mean? It may be that the patient has visited the hospital before, where he picked up the infectious agent. By the time he is now revisiting, maybe because the immune system is now down because of the what's called admission in the hospital. When you're admitted in the hospital, there is all tendencies that the immune system will have gone down small, a little bit. Sorry. So it's now something that has been there before that has not been causing harm may now start causing harm in such patients. So that's why you have a data here that says that 54% of those are associated with previous stay at the same hospital. So that means they were picked up while they were in the hospital, but then it was incubated until another visit. So it is still from the hospital. So then we have out of the 6 that were positive for healthcare-associated infection, you have 92% of them have 1. That is, we have out of the 6%, or out of the 6 people that are associated that have healthcare-associated infection, 92% of them will have at least one healthcare-associated infection. Why 7% have two? It's possible to have two healthcare-associated infections at a go, because there are different healthcare-associated infections. So then we have 1% of them that have three healthcare-associated infections. Can you imagine when you come with a condition to the hospital, and at the end of the day you got infected with three healthcare-associated infections that are not primarily your concern, that is your primary concern why you came to the hospital? So that's to tell us that it's a great threat. So there is a list of organisms here that are commonly associated with the healthcare-associated infection. We have Escherichia coli is an enterobacteriaceae. Just like I said, enterobacteriaceae is one of the major cause, because it is a normal, they are normal flora of the GIT. So it is easy for people to get in contact with them, especially when it comes to poor handling of waste and the likes. Maybe some people, when they use the toilets, they don't wash thoroughly. They use the same hand to handle door handles, to open doors, contaminate the door handles. From there, the infection spreads. So then that is why we have most of them are actually enterobacteriaceae. And they cause species also. They are from the GIT. Then you have what's called Enterobacter species. You have Klebsiella species. You have Staphylococcus aureus. You have Clostridium difficile. Most of these pathogens are from the GIT. And you have Pseudomonas aeruginosa. You have Staph aureus and others. Then you look at the other part of the slide. It shows what form of presentations or what form of clinical conditions are associated with these healthcare-associated infections. So you will see that you have 26% pneumonia or lower respiratory tract infection that are from so 26%, 60% hospital-acquired infection are present from what's called admission, cases of pneumonia or lower respiratory tract infection. Why 26%? So 60% are on admission, while 26% are during hospitalization. You have for urinary tract infections, you have 12% on admission, then you have 21% during hospitalization. Surgical site infection, you have 33% on admission, you have 16% during hospitalization. Bloodstream infection, 8 and 11% respectively. Gastrointestinal tract infection, you have 9 and 7%, and so on. So this shows that these superbugs, these are the spectrum of healthcare-associated infection they cause, and their epidemiology, their percentage. So then, next slide. Okay, thank you. Then this slide introduces antimicrobial resistance, as it has rightly been done before. I know that we've been actually taking through antimicrobial resistance in general before, but this is just because there is no way we can separate the two, because most organisms that cause health-associated infection are antimicrobial resistant organisms. So that is why it is difficult to separate the two. So just like it is shown on this slide, antibiotic resistance is a growing threat to human health. You can also see it from our previous discussion, and we can see it from what we've discussed from the beginning of this presentation. So we've been taught before that the antibiotic resistance is the ability of the bacteria to combat the action of one humans or animals become antibiotic resistant. That is, when an organism that is previously sensitive to an organism to an antibiotic suddenly become resistant to it. For instance, now, primarily, if I have Staph aureus, normally, conventionally, when I use augmentin, that is amoxiclav, it's supposed to cure the Staph aureus. But all of a sudden, I use amoxiclav, the Staph aureus infection is not going. So that means the organism has acquired antimicrobial resistance to the what? To the amoxiclav. So from this, that other slide, the slide you projected now, you have just because of antimicrobial resistance, you have more than 35,000 deaths only in Europe only. So you can see that that is annual death rate too. And antimicrobial resistant organisms they account for over 70% of healthcare associated infection. So we can now see where the relationship is coming from. That is, the bulk of healthcare associated infection are caused by antimicrobial resistant strain. So that is why they are difficult to treat, and they form the major reason why most patients that visited hospital for another reason get longer hospital stay, or possibly even die during hospitalization or shortly after hospitalization. So that's to tell us that this is a great concern, and they have a huge relationship. Then, what are the causes of antibiotic resistance? So, antibiotic resistance is caused by actions and inaction of all of us. Nobody is excluded. So it's not a matter of what concerns me. Am I a pharmacist or am I a clinic? Everybody contributes one way or the other. Just like what was presented earlier, that when you saw that an ordinary visitor coming into an hospital can spread infectious agent into a patient that is recuperating in an hospital. So that's to tell us that everybody is concerned. So look at this slide. So there are a lot of factors that cause antibiotic resistance. One of them is overprescribing of antibiotics, especially in low and middle income countries, because of lack of good diagnostic tools. Anytime any patient visits an hospital, the first thing that comes to our mind is give him an antibiotics. So what we are doing to ourselves is a huge demerit. We are doing a huge disadvantage to ourselves, because as we are prescribing antibiotics for diseases that do not primarily require antibiotics treatment, then we are breeding antimicrobial resistance. Another one is patient not taking antibiotics as prescribed. You were given an antibiotics, good. So you took antibiotics, maybe you took it for 2-3 days, you became well. You say, no, there's no need to complete it. So you are one of the people that are causing the growth of antimicrobial resistance, because you feel you are okay now, there is no need. So the reason is that when you feel okay, it was because the organisms possibly have reduced in size, not that it has completely gone. Possibly has reduced in size, or the metabolic activity has reduced a little. So now you eventually left the antibiotics. So you are giving the organisms room to now plan on how to defend himself against the antibiotics. But if you are given an antibiotics, you follow the dosage clearly, you are not skipping anything. You don't give the organism any breathing space to think on how to overpower the antibiotics. But here we are, anytime almost everybody is guilty of this. Even an ordinary anti-malaria drug, you are supposed to take six doses. So when you take first, second, third, and you are always what concerns me? Please, I'm okay already. There is no point. So all these actions and inactions are causing antimicrobial resistance spread. Then another one is unnecessary antibiotic use in agriculture. This is another area that we are not looking into. When you are doing livestock farming and the likes, we want to improve productivity. We want to make sure that nothing happens to our livestock. So we bombard them with antibiotics. So hoping that we don't want to wait until they get infected. All these are increasing the rate of antimicrobial resistance. So you have a poor infection control in hospitals and clinics. So sanitation practice, all these contributes hugely to antimicrobial resistance, because we have to get rid of these organisms that are harboring the antimicrobial resistance around us. That's the only way we can be free from antimicrobial resistance. Another factor, just like I explained, is the lack of good laboratory. So because most of the disease we manage we don't carry out a right diagnosis. For instance, a patient that has respiratory symptom may be having viral infection that is self-limiting. What do I mean? Self-limiting viral infection means an infection that does not require any treatment. It's going to go away by itself. So, and there is a viral infection. So, a viral infection cannot be treated with an antibacterial agent. So, but because we don't have good diagnostic tool, so we just feel so it's an infection, so we start using antibiotics, and this will cause antimicrobial resistance because the infection primarily is not there. That is, the bacterial infection is not there primarily. So now, how does antibiotic resistance occur? So this first circle we are seeing is made up of primarily susceptible organisms, susceptible bacteria, and only like two resistant bacteria. Now, when you have antibiotics, you use an antibiotics maybe when it was not needed or something like that. So you use an antibiotics. It kills the susceptible ones. Susceptible one means the one that are sensitive to the antibiotics can be killed by the antibiotics. So it kills the susceptible one, leaving the resistant one alone. So when it leaves the resistant one alone, then the resistant one will now keep on multiplying because the space and every other resources is available for it now to multiply. So it keeps on multiplying, then from there it spreads. So that is just the simple explanation for how antibiotic resistance occurs. And that is why we don't use, we must caution our irrational use of antibiotics, because as we are using antibiotics, we are killing the ones that are susceptible, paving way for the ones that are resistant. Then, how do antimicrobial resistance spread? There is a difference between, okay, how do we come about antimicrobial resistance to start with? Then another one is, how do they even spread? So you can see that there is an interplay between different units. So you can see that animals are using antibiotics, human beings are also taking antibiotics indiscriminately. So when that happens, then the antimicrobial resistant organism becomes selected. How do I mean by selected? That is, when you clear off the organisms that are sensitive to antibiotics, that are competing favorably for space and nutrients with those that are resistant. When you clear the sensitive one out, you select the resistant one, thereby allow the resistant one to grow. When they grow and multiply, so they are ready to spread because they have their number now. So from there, if you look at this chart very well, so it's a case study of someone just named George. So it states it's either George, when George get antibiotics and develop resistant bacteria in his gut, it's either just stay at home and in the general community spreading the resistant bacteria. Either when he goes to the toilet, he uses the toilet, he did not clean up well, the hand become contaminated, he uses it to open the door not become contaminated, someone else coming, opens the same door, so carries the germ that harbors antimicrobial resistance because of George's irrational use of antibiotics. Then this one now spread, goes somewhere else and starts spreading it. So then the George gets care at hospital. Maybe he has an infection, he gets care at the hospital. So when he was in the hospital, the resistant germ gets spread to the health worker handling him, possibly because of their poor infection and prevention control measures. So as you are handling the patient, it is possible for you to transmit a vector agent to the patient. Likewise, the patient can transmit the vector agent to the physician or to anybody handling the patient. So it's not a one-way thing; it's a two-way thing. It's just that the physician may not come down with the infection, possibly because of the point of contact with the infectious agent, or because of his immune status at that particular point in time, because he has good immunity at that point. But what we are saying next is that the bacteria can they'll naturally be transmitted from from the patient to the physician as well. Just like it can happen to from the patient from the physician to the patient. Then it goes like that. Then vegetables get contaminated. Use manure from animals that have overused antibiotics. Vegetable got contaminated. Then we eat the vegetable. Someone else eat the vegetable. He carries the antimicrobial resistant strain of bacteria. So the cycle continues. Nobody is excluded. So now, as rightly explained now, so how do we now measure the burden of this thing? That is why this slide is there, that shows the global impact of antimicrobial resistance. You will see that most disease conditions or most challenges are always restricted to the low and middle income countries. But in the case of antimicrobial resistance, it's a global thing. And that is why from here you can see that from North America you have 370,000 deaths annually it was projected by 2050. By 2050, 370,000 deaths will be attributable to antimicrobial resistance. It continues like that. In South America, 392,000 deaths. And in what's it called? In Asia, you have about 4,730,000 deaths. In Europe, you have 390,000 deaths. In Africa, we have 4,150,000 deaths. Then in the far Australia, you have about 20,000 deaths attributable to antimicrobial resistance. So this is huge for us as a global community, and we all hands must be on deck to ensure that we are all responsible to ensure that the threat of antimicrobial resistance goes down the drain. Now, healthcare settings as the major cause of antimicrobial resistance. We may want to know that is there any peculiarity in the healthcare setting that made it a breeding space for antimicrobial resistance? So the main reason is that we use antimicrobial agents a lot in healthcare settings. Just like I rightly said, even cases that do not require treatment or cases that do not require antibiotics. So we use antibiotics for different reasons. Some for prophylaxis. They may say, okay, because we want to go into surgery now, we don't want a situation whereby you are going to be exposed to an organism and you now get infected, then it's going to be difficult to treat. Let's use antibiotics as prophylaxis. So these are the different classes of antibiotics that are used routinely for prophylaxis, for treatment of even viral infections that primarily does not require antibiotics. So these are the antibiotics, and these are the common antibiotics that are available. So because we use these antibiotics routinely in the hospital environment, so it caused a lot of natural selection, such that the antibiotics, the organisms that are present in the hospital environment are antimicrobial resistant organisms already, because they've been exposed to antimicrobial agents often and often. So the ones that has been selected out. So the ones that are circulating in the hospital environment are the ones that are resistant, because they've been overexposed to antibiotics. So you can see how it grows. So from for different reasons we use antibiotics. So just like it is shown on the slide. Next slide, sir. Okay, so the explanation we made now, it may not really make sense to us, but this slide is going to explain it better. Because just like I said, you may want to ask me, what is there if I take antibiotics? What's there? So the antibiotics we are taking has a lot of effects. One of them is selective pressure. So selective pressure means that an organism that is susceptible becomes killed, paving way to organisms that are resistant to multiply. This happens a lot in the health sector because there is a lot of antimicrobial usage in the health sector. So these select organisms that are resistant thereby difficult to treat, and they can easily spread because as you are trying to disinfect, they are resistant to disinfectant also. So they are very difficult to eradicate. Then there is another thing we call fitness cost. What is fitness cost? The genome size of each antibiotic seem to be fixed. For instance, now you have the genome size of each organism seem to be fixed. So there are some situations whereby you have maybe Klebsiella pneumoniae now, maybe it's around 5 kilodaton. Maybe that's the what's called that's the genome size. It is difficult for it to acquire anything outside that 5 kilodaton. Well, if that organism happens to be in the hospital settings, just like we said, there are a lot of traits on the organism, but importantly, the virulent trait and the antimicrobial resistance trait. So it is the same space that all these traits compete for. So organisms in the community, because they are not routinely exposed to antibiotics, so they have more virulent traits. So because the space on their genome will be occupied by virulence factors, whereas those in the hospital community, the space in their genome will be occupied by antimicrobial resistant genes, because they've been constantly exposed to the antibiotics. So the fitness cost, the meaning of fitness cost is, in most cases, is either an organism is hyper resistant, hypovirulent, or hypervirulent and hyporesistant, because they are competing for the same space. So it is the same space that they occupy. However, in the recent time, the organisms are evolving that are hypervirulent and hyper-resistant, and that is where it threatens the public health more. Because we are always like before that, okay, if an organism is not too virulent, and it has antimicrobial resistance, since it is not too virulent, the lethal effect may be minimal or it may be slow, while we are looking for an option to treat the infection. We may start to explore other options, like, okay, let's see, most antibiotics do not work. It may give us ample time to look for another antibiotic that can work. So because it is not virulent, so it's not going to kill fast. However, those that are virulent, we are almost sure that, okay, they are virulent, but immediately we get an antibiotic to them, because they are not antimicrobial, they are not resistant. Immediately we get an antibiotic, they are going to get cured. So it was a kind of balance before, until recently, where hypervirulent and hyper-resistant organisms are coming on board, where an organism will be very virulent and at the same time be resistant. So this represents a greater threat to the public health. And the patient is dying, and you are not getting an antibiotic to cure the patient. So that is why. Then another thing is bioinformation, just like I explained. Bioinformation is just community of organisms. Some organisms have ability to form community around a biotic surface or abiotic surface. Biotic surface means living surface in the living cell, whereas abiotic surface means surfaces that are objects, inanimate or object. So these organisms, so when you use intravenous catheter on patients that are clinically ill, these organisms form biofilm around this catheter, thereby preventing antibiotics from penetrating into the patient. So when this happens, the organisms in the biofilm fold become more resistant, and as they become more resistant, they tend to spread their resistance mechanism to the neighboring organism that they are together in the biofilm. So that means biofilm is one of the major ways of breeding antimicrobial resistance in an hospital. So that is why it's very important. So is that the prefect of head-associated infection. So just like it's projected here, so we have it adversely affects performance and image of hospital. When there is an hospital that anytime a patient gets there, even if he goes there for a minor issue, it became complicated because of infection with an healthcare associated infection, thereby causing long hospital stay or even death on the part of the patient. So the image of the hospital is adversely affected. Then, just like I said, prolongation of stay in the hospital. So because the physician will be battling with trying to cure the infectious, the what's called the healthcare associated infection, and the patient is not getting well. So the what's it called? The patient has to be in the hospital until possibly the infection gets cured or the patient eventually dies. Then you have increase in the morbidity and mortality of the patient, of course, because if an organism is resistant to antibiotics, then it may be difficult for it may cause more morbidity, that is going to cause more damage in the patient. Then there is increased mortality rate, that is more patients will die because there are no antibiotics option for their treatment. Then you have increased bed occupancy. You hear situations of when you get to our hospitals, they say there is no space, they are rejecting patients. One of the reasons why they are rejecting patients is some patients have been there for a long period of time because they were infected with healthcare associated infections that are antimicrobial resistant. So they don't give room for new patients to come in. Therefore, the situation is not only on the people that have the antimicrobial resistance, but also on patients that are supposed to come into the hospital, they cannot because there is no space. Then the hospital, community and national resource put under severe strain because there is a lot of money that goes down the drain because we are trying to curtail hospital healthcare associated infection. So it causes a lot of stress in the economy. So this is shown in this what's it called, in this chart. You can see the amount of money that goes into treatment of hospital acquired infection in the US, and this can be prevented if everybody is ready to do that, and that is why all these advocacy are very, very important to the global community at large. Next slide. Yes. So how do we now how do we ensure that how do we ensure infection prevention and control in the hospital? So it is very important that this policy must be on ground such that spread of antimicrobial resistant organisms will be reduced to the barest minimum in our hospital. So these are the basic steps that are required for good infection prevention control. You can see hygiene, just like I said the other time, the major cause of one of the major cause of a source of infection is medical personnel. Some of them, they are interspace harbors antimicrobial resistant organisms, and when they are manipulating the patient or they are handling the equipment, it gets deposited on the equipment, thereby affects. So good hand hygiene, the use of PPE. PPE means personal protective equipment. So like gloves, masks, and the likes like that. Then gown, that is the use of lab coats and some other gowns that may be needed. So it depends on the nature of the disease that you are dealing with. That's what determines the level of containment you are going to put in place. Then you have patient care equipment. You must ensure that all those equipment used in treating patients are well sterilized to prevent transmitting an environmental organism into a patient just because it's getting care from the facility. Then another one is environmental control. Just like I said the other time, just like the case of One Health approach, antimicrobial resistance is not a human being thing alone. So it cut across the three important aspects, which are the human being, the animals, and the environment. So environmental sanitation or environmental disinfection is very, very important Then you have occupational health and blood-borne pathogens. So they have to be well taken care of. So because you have to make sure you prevent injuries. You don't just handle things carelessly. That what is my own business there? So when you are using anything, make sure you prevent injury, because any breach of the skin or the intact, the already intact what's it called intact surfaces, any breach in them may cause acquisition of these antimicrobial resistant strains of infectious agents. Then you have patient placement. So if a patient has a particular infectious agent, there must be a specific provision for such patients, so that it's going to minimize the spread of the antimicrobial resistant strains of what's called of organisms. So next slide, sir. Now, the previously listed control measures, we may feel that well, this is none of my business because I don't work in hospital. How do you want me to now be doing all those ones? Right. So now we have a role to play also as what's called as individual that are outside the hospital community, and this is where this comes in. So what are those steps that are needed to ensure that we don't transmit, or we don't get infected with antimicrobial resistant organisms, and we don't spread it? One of them is that whenever you go for hospital visit, you don't insist that doctor must give you antibiotics. Let them do the proper diagnosis. Don't be in haste. In most cases, disease don't kill like what's it called, within hours, or else even if you have any time at that point, it may not be of any help. So it's better you take your time, let them clerk you, and let them have a working diagnosis. So don't insist that doctor will not give me any antibiotics, so that you don't end up breeding antimicrobial resistance. Then another one is that you must practice good hand hygiene, hand washing, and others. For instance, when we go to the toilet, we must make sure that our hand hygiene is well done. We don't just go to toilet and we hastily go out of the toilet. That is a bad practice, and we are breeding the spread of what antimicrobial resistance, because we are by the microbial gods. Because of the previous antibiotics we've used, they have already acquired antimicrobial resistant genes in them. The only reason why they are not harming us is that in that site, they are not meant to primarily cause infection. By the time we use the toilets, we use our hands on unclean hands to open doors, so we contaminate the door handle. The next person coming in contact with the door handle may touch a patient or may touch an open wound, thereby causing the infection by the antimicrobial agent there, antimicrobial resistant organism. Then another thing is never take antibiotic for viral infection. Like I said, most viral infections are self-limiting. Self-limiting means immediately they finish their course, it goes away. For instance, someone that has upper respiratory tract infection that is not due to streptococcus pyogenes don't need any antibiotics. So, but because of the symptoms, we want to say, doctor, please just give me an antibiotics. I want to make sure these symptoms, I'm relieved of this symptom. You don't need, so don't take antibiotics when you have viral infections, because it cannot work for it. You rather kill susceptible organisms in you, thereby breeding antimicrobial resistant organisms. Then another thing is that you maintain a healthy lifestyle by eating a balanced diet, then drinking enough liquid, exercising, and getting enough rest. This is very important because the organisms that are antimicrobial resistant, the organisms that are antimicrobial resistant that are primarily in a patient or in someone may not cause any harm if the person is immunocompetent. But if all these factors are not there, it may cause immunosuppression, which may eventually allow the organisms to multiply and now cause infection. Then another thing is that you must make sure that you must never take antibiotics that were prescribed for someone else. Don't just say, the last time my friend goes to the hospital and he complained of this particular symptom, that this I have similar symptom too. So that means I should take the same antibiotics. No, the case should not be like that. The case should be that go to the physician, then let him be properly clacked, have a diagnosis, then have the correct prescription for your own unique disease condition. Then never take antibiotics that were left over from a previous infection. Maybe you've been to the hospital before and you were given an antibiotics. Possibly, maybe you finished the antibiotics dosage, you were able to do that, but you still have some left. So now you are now having similar symptom. To you, it is similar. So instead of just saying, maybe when I have this kind of condition the last time, this is what I took, so let me take it again. No, because there are what's called infections have a lot of similarities. They have overlapping symptoms. So this infection you are saying now may be different from the previous one and may require another mechanism of management. So if you don't know that and just use antibiotics like that, instead of tackling the main issue, you end up breeding antimicrobial resistance. So healthcare-associated infection and antimicrobial resistance overlap widely, but they are not the same. So that we don't make that mistake. Though there is a thin line between them, they are not the same. And we must know that, but they largely overlap. Healthcare-associated infections are often caused by antibiotic-resistant bacteria, so that is where the overlap is coming from. And just like I said during the course of this presentation, most of organisms become resistant from the respiratory environment because they've been over time they've been exposed to antimicrobial agents, which made them resistant to those antimicrobial agents. So, but the hospital-acquired infection are often caused by antibiotic-resistant bacteria. So, CRE is a carbapenem-resistant enterobacteriaceae. Carbapenem is like the last drug of resort. Carbapenem is like the last drug of resort. So, and they are already circulating in the hospital community. So, if a patient is infected with carbapenem-resistant enterobacteriaceae, it may be difficult to treat such patients because carbapenem is like the last resort. Then we have methicillin-resistant Staphylococcus aureus. MRSA is another superbug that threatens the healthcare sector because it's one of the circulating strains of healthcare-associated what's called infectious agents. Then we have a vancomycin-resistant enterobacteriaceae. So this is another superbug, and it causes a lot of problem in the health sector. So because they've been selected already, so they are the ones circulating in the environment. So any breach of normal immune system will eventually cause infection with these superbugs. Then you have a good infection and prevention control. So this is the only way. This is the only way that we can actually get our hospital in place to make it safe. If we don't have good infection and prevention control, the hospital may not be safe. Of course, for now it's not safe, but at least we have some infection control is very, very important to ensure that even if antimicrobial resistant strain are present in the hospital community, they must not spread. Spreading is the major concern, and the only way we can curtail the spreading is by having good infection and prevention control measure. So I think we've learned one or two things today, and questions and observations are welcome. And then from there we can also forge ahead. So how do you think we can stop these menace? These are my selected references. Thank you.
Wow. Please let us give Mr. Hamzat is a flower. He deserves the flower. Let's give him his 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 flower. Something that I could see in him, and some of even all of our members are commitment. And this question happened when we were writing one proposal, and somebody asked that this is a huge task. Do you think that you are not going to be paid for it? Are they paid for what? Our members have been committing their time and their knowledge without even thinking of what to benefit or even payment. That it is the commitment and the passion that is actually driving the GSLSN. And this is very, very evident in the way we see people traveling, they join, people at the meeting, they join. Mr. Hamzat is one of the key and strategic principal personnel in that very hospital. And that's the reason why he is actually trying to maneuver, to present, to continue, present, continue, and also try to maneuver so many things. I think it can only take passion to do this. The simple response would have been, I am busy, please. I am very sorry, I cannot do it. And many people are actually joining at the time that is all convenient. Like Professor Flores supposed to be resting now. See Mr. Richard Walese at a meeting in the office, still passionately following. Chef Ina is actually attending a meeting in a children's school. And see, everybody is busy. Like many people will be in their car traveling, and they will still join. So a lot of things. So what you are trying to say is that I want to thank you most sincerely for this very sacrifice and for this very dedication and for this very commitment. You see, for me, I believe in something. If you give freely, people are going to sacrifice freely for you, and that is just the magic. There is no amount of money we want to give to anybody here that we can afford. We cannot even pay. We cannot even pay for it. We can't pay for it.
Thank you very much. Honestly, Mr. Hamzat. Abi, do I get the name right?
Yes, sir. Yes, ma'am.
You have done a very diligent work. A very diligent work. We cannot pay for your knowledge. The Lord will reward you. Because, you know, there is no amount of money that we can pay that can commensurate with what you have done this morning. I want to tell you, it's a great expository research. For me personally, I learned a lot more. And I will be more careful based on all this. So I never knew that when they are asking us not to visit patients in the hospital, they are trying to help us so that we don't increase certain things. And do you know, I'm one of those people that will start my antibiotics and I will not finish it. So, and always it will reoccur. I will not be wondering, is your augmentin not working again? Is this thing not working again? I didn't know that when I left them on finished business, they will not gather us together to do a lot of effort. So thank you very much. This topic is very, very good and it's contemporary. Like Dr. Adebisi mentioned, there is no sustainability when we cannot work on our health. Because we cannot live as a part. It's a whole thing. Sustainability is a whole thing. And you know where things are working for them. In other continents, apart from Africa, that we look at the number quoted that we die in so year if we continue this way. You know, people take precaution, but we will take things for granted. Now I will be more conscious that when I even open a door to the public toilet or school toilet, when I get back, I'll go and wash my hand. Because I don't know what antibiotics that person has abused and is turning to don't mind me, I'm not a scientist, microbial resistance of antibiotics. So as you are presenting, I'm thinking of going into a research. I'm sharing with Dr. Davidson already. A research that will just, because there are so many people dying out of ignorance, including myself. You know, that you have explained certain things to us that will make us to be able to do it. And the only way we can do it well is to transfer the knowledge acquired here to other people. So that from one person to the other, we become peer educators. So once again, thank you very much. And I want to give kudos to Dr. Davidson for getting this kind of research to us. Thank you very much. God bless you. And to everybody that is participating. I know we learned a lot.
Yeah.
So I promise not to mix my classes again. Yeah.
Mr. Richard. Mr. Richard, yeah, you have the floor now.
Yeah, thank you. I am just so amazed with the presenter. He has really given us the information. Actually, I was reflecting the time when we had COVID. He's just reminding us about the SOPs, the standard operating systems. And it is every other person is conscious. Even greeting now, you even think of getting scared, greeting hand to hand. But the message was very clear. Somebody in the office here is telling me, even on these tables, even on these chairs, like you can find infection everywhere. I think I have to appreciate so much the presenter. But to me, my uptake is I think we should preach sanitizers every other time. Thank you. So, like everywhere you go, you must move with the sanitizer in your car, your sanitizer in office, your sanitizer in, you know, this is how we can, especially in rural areas, you see a lot of hospital infections because those people in the village, they care not about their dead person. You know, I've been a community health worker and I've been riding a tricycle ambulance. But there are times that we have been handling emergencies of cholera. These people just touch their dead, maybe sick person, their dead person, no? And they carry back the infection to the communities. Thank you so much. You've done a very good presentation.
Thank you, sir.
Thank you. Thank you so much. And another thing that came to my mind was the issue of medical doctors or the people in the hospital that we are relating with. We shouldn't compromise standard. And that is what I used to do. If I see you as a medical personnel and you are careless, I will tell you, you are not the kind of person that can treat me. Because the way you are doing doesn't show that you are professional. So we should be bold enough to correct these medical personnel that are careless and want to attend to us. Even when they are doing what is not right, we should be bold enough to tell them. Because a lot of incidences or accidents has occurred due to carelessness of some of these negligence from some within the medical system. So we should be bold enough to tell people, even if it is their profession, if what they are doing is all right. Like if anybody want to give me injection when I used to take it, I will ask, is that a new needle? If I am not sure that it is a needle, I will ask the person to change. Let me see that it is a new needle. So they will say, what happened? Yes, it is our right to be bold, to be careful and to monitor what they're actually doing. Have you sterilized what you want to use for me? He said, no, especially all the very private hospitals that normally manage resources. We should be bold enough to tell them, and if we see them, not only that we should be bold enough to actually tell them, but to actually report them and monitor them.
Thank you so much, Dr. Said. It is really interesting and very informative. The presentation by Mr. Amzat was really impressive and very interesting, too informative. And I would like to say that the chefs play a very important role in presenting the food, because food plays a significant role in hospital-acquired infections in several ways, right? Source of contamination, the food can be a vehicle for pathogens if not handled or prepared correctly, right? It can carry different viruses, bacteria to the patients in hospitals. It is very important for the chef to be very healthy. It should be a rule in every kitchen that the chef should get regular checkups, monthly checkups, so that the viruses or bacteria, if they are carrying any diseases, should not be transferred to the patients, right? I think that is the main very important issue. After that, cross-contamination in hospital kitchens or dining areas, improper handling of the food can lead to cross-contamination between raw and cooked items, increases infection risk, right? And nutrition and recovery, adequate nutrition is essential for patient recovery, and malnutrition patients may have weakened immune responses, make them more susceptible and to hospital acquired infections, right? So the food should be carefully packed, preserved, and very carefully served. And the chef should be informed about the patient, what should be the best nutrition for the patient, which should be served to him as a meal, as a dinner, or as a breakfast, to give him a proper immunity system or a strong immunity system, right? And that's it.
Correct.
As a chef, I can suggest this.
This is very wonderful one from Chef Zanim, that how chef can actually help in reducing the microbial loads and also the microbial resistance within the society. And this is very, very thoughtful, very, very thoughtful. The people that are working in the hospitality business, how much care are they paying to their, how much attention are they paying to their health? Some of these people may be sick, and because they are within the system, they may not even take care of them. Like it is your work, you must do your work, you must do your work, you must do your work. Instead of giving them rest, to go and rest. Instead of giving them support to recover. Instead of giving them a lot of things to, this is another perspective entirely. And you know, these are people that are actually preparing food for the society. The food that they prepare, cross-contamination, increasing microbial load, can get transferred easily into the society. That's the one perspective. The other perspective is that if the chefs are aware of this very microbial resistance, antimicrobial resistance, it can help them to even design menu. That when you see a customer, when you are serving a particular system, maybe hospital system, a school system or something, you should be able to advise them on what they can do to actually reduce the microbial load, and also even advise them when there is a certain special treatment for special people within the population in that system. What kind of food can we serve them? What kind of meal can we, menu can we design for them? So this is another perspective entirely. And now coming back to our home. Wife will be sick. The husband will insist that the wife should cook. Endangering themselves, the whole family. Endangering themselves, the whole family. Because she is the wife. Because she is the wife, she is the only one that can cook and that must cook. But she is sick, carrying the microbial load that can kill the whole family. But you don't give her rest. You don't have that very understanding with her. So these are the issues. These are the issues. And you can see the perspective of where Chef Zanim is coming from. So, and that's the reason why we say that it is all encompassing. Chefina, yes, Chefina.
Yes, Dr. Saeed. I heard all the session throughout the session in the school of my kid.
Yeah.
Dr. Hamzat and Florence, everyone give a good clearance about this topic. Alhamdulillah. Or the Chef Zainab also talk about that. But all the session I heard my heart. What is the last line? What do you say? The backbone of all these subjects, even the sustainability, even we are talking about hospitals, the restaurant, that cafe. The one word I would like to say is hygiene. If we control hygiene, so we can control our disease, we can control the infections. So the basic of the root word, I say that it is a hygiene wherever you are. So if we control, the hospitals control the hygiene, the chef line, they have to control the hygiene. So we can control the all type of diseases and infections in our life. So we have to be emphasized everywhere and give the awareness regarding sustainability, that hygiene is more important than everything. It's just like oxygen. We are taking oxygen, so we have to be care about hygiene. Or to the women, because mostly the women are take care of their kids or the home or the hygiene. So hygiene in the kitchen, hygiene in the washrooms, in the toilets, so each and everywhere, or even the hospitals. The mother is also take care of the kids. They bring the kids to the hospital, and there are took infection from the hospitals. So again, we have to be give awareness throughout throughout the families, by to arranging the arranging the people who are, we are responsible for that. If we have the knowledge about that, we have to be spread each and everywhere. So we have also make some take a step and keep some in the community, keep some teams arranged to give the awareness step by step regarding the hygiene and getting infection and these type of things. So that is my perception regarding everything. Yes.
Yes. I think the point that Chefina was making was the hygiene in totality is very valid, and I think we can design the focus around that as well. But what Professor Flores was actually saying was that we can make it all encompassing, not only looking at the university that we actually want to target, we expand it to the people at the restaurants, at the family level, to actually contribute to this very baseline survey, to have a comparative from different countries and different backgrounds. Propma, is that what you are trying to pass across?
Trying to say, that is it, so that we can have robust baseline information. That based on that, we now design the strategy to reach every one of them on this earth sustainability, which is going to be a robust one. That's what I'm saying. Thank you.
Thank you so much, Ma.
Well done, sir. Mr. Asamomin is a senior colleague. He's also a scientist. I don't know that he has actually joined. Yes.
Yes, Mr. Asamomin, please talk to us.
I want to thank the presenter. I appreciate him very much.
Yeah. Mr. Asamomin, please talk to us. Maybe he is somehow busy. Yeah, okay.
Job for our doctor fabricators, Dr. Said. I'm really appreciate our speaker. Really appreciate for your presented of what you have touched about the earth. As we all know, this is our community. or let's say global generally, issue of health is affecting the communities by abusing or inadequate learning. Let me say inadequate of learning, or let me say lack of learning, because if you are not know anything about this discipline or professional parts, you cannot say that you know something. Your discipline is going to be make you as a professional in your own aspect. So we really appreciate the global for giving a morality and experience and learning. We really appreciate. May Almighty God be with all of us. Thank you very much. I'm really
for this Saturday talk. Something I think it should be the foundation and the continuation of what we had last week. So because the speaker for today made the session delve into that of last week, let us to know about some foundation of the main cause of this all these germs and these communicable diseases in our environment. What I will just try to input is that, as one of the contributors has said, that personal hygiene, personal cleanliness and general from the individual and the general populace. The government contribution also, because there is a program that's always going on in Nigeria before. I don't know, maybe it's here in some states. There is a particular day that is a general environmental day, that every area will be clean. Every gutter, the drainage and everything will be clean, will be free from germs and all those things, including our inside our house. Because those people that we inspect that particular place will be there, will be on ground to check. And if anybody found one thing, that person will be prosecuted. If the government can continue this kind of a thing, I think it's somehow reduce or sometimes prevent the spread of all these communicable diseases, all the pathogens that causes all these germs and communicable diseases in our environment.
So we allow our speaker to actually give a wrap-up remark about everything that has been said. Then we will close the session for today. Mr. Hamzat.
Thank you very much for this opportunity once again. Sincerely, I want to appreciate everybody that has contributed, and what we've all contributed, nothing but the facts. Just like it has been rightly said, hygiene, very, very key. Because a lot of this burden can be reduced from good hygiene. Ordinary hand washing hygiene will go a long way. So we should take it serious, and we should be deliberate about it. Hygiene. But just like one of the commenters said, that even on surfaces, even in the hair, we have microorganisms, and what's called disinfecting every time we go a long way in actually reducing the spread of this antimicrobial resistant superbugs. So thank you very much. Hygiene, once again, very important.
So we should turn it to a song now. Hygiene, and hygiene now.
Exactly.
Adebisi Adesat, you want to say something?
Yes. Good morning, everyone. Good morning.
Good morning.
Thank you, Professor and others in the house. And I really want to appreciate my colleague, Dr. Hamzat. It's not official. Yes, you are going there. I think he is busy, but he is as stuffy as ever. Mashallah. Thank you for all very much. So hygiene can never be a complete program for now. So we can get rid of this stubborn AMR that is threatening our healthcare. And we ask all of us to please preach it anywhere and in every place. Thank you.
I think when a child is calling, when a mother is calling the child stubborn, and definitely that very mother has known the child very well. So when a professional is calling AMR stubborn, it has really made their life something in the lab. Thank you so much. Professor Femi Ajayi, yes, we want to close the session for today. Please do the closing for us if you are available. Thank you.
Let me say thank you to our presenter, Mr. Hamzat Ademola. You can see that I've changed my background again. I am now appearing in the shirt, almost set to be on another journey. Thank you so very much, Mr. Hamzat. That was a very fantastic presentation. Every presentation that doesn't generate argument, that doesn't generate comment, that doesn't generate criticism, that doesn't generate request for addition is a dead one. I know Professor Yusuf will agree with me that even when we are in conferences, you make presentations, there are no either commendation, either criticism, either charging you to look at it from other side. That's why we have group of researchers. It means that you have successfully made a presentation that has really agitated our mind. And that's why I can say that it's your presentation that dragged us to 14 minutes after 11. Usually we finish at 11. Your presentation has been so fantastic and successful. I give it to you. You are such a wonderful presenter and a very beautiful researcher that is worth the onions. We are very grateful. We thank you for coming, for accepting to make presentation in our GSLSN. And by this presentation, I strongly believe that you already become our member. So you have willingly enlisted. Thank you so very much. By and large, we have come this far in today's activity. After thanking you all, I want to say that GSLSN is here to stay and is moving forward and ahead. Thank you again. I appreciate you all. I congratulate all of us. I congratulate Dr. Adebisi. I congratulate Mr. Hamzat Ademola. Well, somebody called you doctor. I think that's what people will be calling you in your hospital. People that don't even know what you are. By the time you put on your garment, because I know you are the one that will be using so much of all this lab coat and the likes. Thank you so very much. I appreciate you all. Do have a very pleasant day wherever in part of the world you are. Thank you again. Thank you so much.
Thank you so much. And bye-bye for now. We are going to meet again next weekend. Yeah. And it's going to be a hard talk.
Chef. Bye.
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 Thank you so much.